To our 816th CME, and Dr. Chauhan, would you say this is the 18th year? 18th year of continuous non-stop CME. That's our So friends, I have a proud privilege to introduce, of course he doesn't need any introduction, he is the, would you believe, he is the youngest oncologist in India? Believe me. He was the dean and professor and head of oncology at AIMS till 2015, and then he joined Max, and he was pivotal in setting up the Max Cancer Daycare Center. And it's been at Nagar, it's been a fantastic journey for Dr. Julka, and he's also received higher training at Anderson Hospital, Texas, and as I said, he was dean and professor in Department of Radiotherapy and Oncology at AIMS. Dr. Kapoor was at AIMS previously, and former president Association of Radiation Oncologists of Indian chapter, of Northern chapter, and the former chairperson of the Indian College of Radiation Oncology 2000 and 2000 till 2009. So Dr. Julka is going to talk on daycare oncology, chemo as well as immunotherapy. Dr. Julka, please.
Thank you very much, Dr. Tulsi, for excellent remarks. I think
नहीं आप यहाँ से बोलना चाहते हैं कम देर नहीं यहाँ से बोल सकते हैं
सर वो आप वहाँ से कर देंगे आप यहाँ से बोल सकते हैं नहीं खुद तो स्लाइड
ओके
वो है सर आपको दिया है वो स्लाइड पे
आप इसको जरा
थोड़ा लेफ्ट एक्सेस डेविएशन करो
ठीक है बढ़िया
नो ज़्यादा मत करो यार कैमरे में ठीक
as you heard that Max Lajpatnagar is a center, daycare center for chemotherapy, immunotherapy and all the latest molecular therapies in India, and not only in Delhi but in India. We are doing all the latest things in cancer care. This is pure oncology center. Now, what I want to show you, this is the Max Daycare Center at Lajpat Nagar. And again, if you see, in Hindustan Times also we had a big article and comparing us to Sloan Kettering and MD Anderson Hospital. And we have been, cooperating together with Sloan Kettering and MD Anderson Hospital in the US, and because since I was at MD Anderson Hospital for a long time, and I had taught in the US as a visiting professor in UCLA. Now, if you see the daycare center, these are the procedures, because before giving chemotherapy to any patient, we must take a consent. And creating a plan in accordance with the disease and circulating, calculating the dose and duration of the drugs with any adjustment if so applicable. Now, counseling patients for long-term side effects is also very important, because not only taking the consent for chemotherapy and immunotherapy, we also counsel the patient for long-term side effects and short-term side effects of chemotherapy, and blood tests and all these tests which are related to CBC, LFT, KFT, all these are done before starting chemotherapy, and fixing any present infections to decrease the possibility of complications through chemotherapy treatment, because some chemotherapy may diminish your body's ability to resist infections, because the immunity is likely to go down. And important to make arrangements in their office and home, since it is provided as an outpatient clinic, because it is a daycare center. Now all these are daycare chemotherapy processes. During procedures, chemotherapy, immunotherapy drugs can be given in various ways. Infusions are there, pills are there, injections are there, certain lotions which may be given. And all these chemo and immunotherapies are being given at max length. Now, if we see the after effects of chemotherapy, they are nausea, vomiting, diarrhea. Of course, we take care because we are giving pre-chemotherapy, certain drugs which prevent all these side effects. And loss of appetite. And hair loss is one of the most important things because, especially the ladies are more concerned, breast cancer patients are more concerned with hair loss. And we always tell them hair loss is temporary. After the chemotherapy is over, hair will come. And I always tell them the hair will be black and it will be curly. So you don't have to go to a beautician for marriage. So that gives relief to the patient. And besides that, there are fever, constipation, bruising. So number of side infertility is another side effect which will be met by Dr. Survi later. And kidney problems, nerve damage, heart problems. So number of side effects are there, but we manage them all as a daycare center. We don't have to admit the patient in the hospital. Now, services provided: daycare chemotherapy, immunotherapy, and targeted therapy. Targeted therapy means we do the genetic profile. I always tell the patients that, you read Janam Patri for, the horoscope for your marriage proposals and all the other proposals. And we have your molecular horoscope. This is a molecular horoscope. We are getting it done either from the US or from India. Any center, molecular oncology center, we are getting the molecular profile of the patient and then give targeted therapy. Suppose one gene is mutated, we give therapy according to that. And you will be surprised to know that lung cancer patients, in 1980s or 1970s, when I started my practice, late 1970s, the lung cancer patient in stage 4 used to live for 6 months to 8 months. Now the patient is living for more than 5 years. Months have changed into years. Why? Because of targeted therapy and molecular profiling. Supportive care is done, and we have dedicated home sampling and medicines, home delivery, and other home care services, radiology and lab services, and chemotherapy PICC line procedures. We have PICC line procedures, and we do chemoport also. I was talking to Dita that why not get the chemoport done at max per sheet. She said we need a special surgeon and who should do it. So we have comprehensive OPD consultation also, because we have medical oncologists, we have surgical oncologists, we have radiation oncologists who come on weekly, once a week, twice a week, or thrice a week, and palliative care medicine. Then we have head and neck oncologists also coming to us. And we have nutritionists and clinical psychologists who gives consultation. Then there are minor procedures and blood transfusions are done inside the daycare center. Now, the health world also said MICC organizes press conference to create awareness around breast cancer. The other day we had organized a breast cancer survivor camp in, at Lajpat Nagar, and there were so many breast cancer survivors. There were so many breast cancer survivors who could come, and they gave talks also. And the patients, I must tell you this, the patients whom I treated in 1985 or 84 attempts, they are coming for follow-up. You can believe that more than 30 years follow-up is being done at Lajpat. And one ignored a pain, the other not. Breast cancer survivors on what not to ignore. So basically, what I want to say that even doctors are ignorant about breast cancer. One of the lady doctors came to me, I examined the doctor, and after palpation I told her that it is a 1 centimeter lump. Get the biopsy done. And we generally get the biopsy done at Max Saket. So we have Dr. Rita Bansal who does MR mammograms and biopsies. And I told her, she said, I don't have time to get the biopsy done because there is no pain. So painless lump in the breast means breast cancer. Not all painless lumps are breast cancers, but it may hint as breast cancer. Biopsy must be done, or FNAC or biopsy, because FNAC sometimes you miss, but biopsy you cannot miss because there is larger tissue. So that is why I told, and she didn't have time. She was doing cesarean. I've got 4 cesareans. I've got so many cases to see, and ultimately she succumbed to the disease because she went into Ayurveda. I am not against Ayurvedic or any other system of medicine, because I was advisor to the health ministry, and we had started Ayush. Ayush is the Ministry of Health, under the Ministry of Health, which does research on local, like Ayurveda, like homeopathy. So I always tell them that you must do research, you must do clinical trials so that you can prove that one drug is useful for a particular type of cancer. Unless and until you prove.
Because we can conclude and have some questions later on.
Yeah. And just last slide, that I wanted to highlight certain patients. Mr. Baldev Raj is a 79-year-old metastatic colorectal cancer, and he had, on molecular profiling, he had KRAS exon 2 mutation, MSI microsatellite instability was high. So based on these, I started on pembrolizumab immunotherapy and bevacizumab, and patient is living for more than 6 years with metastatic disease. Now Ritu Goel.
Your next patient, Ritu Goel, is my patient whom I referred to you, and she was being originally treated at Singapore.
Yes.
She is doing very well. She is my neighbor.
Ritu Goel is doing very well, and she
12 years now?
12 years. And she is metastatic with brain mets.
Yes.
And she is living a wonderful life. Can you believe it?
Yes.
And then triple negative breast cancer. Triple negative breast cancers are worst cancers. And she has completed 5.5 years, and she came and thanked me. So all these patients I wanted to highlight that there are many other patients whom we have treated, and more than 20-year follow-up for triple negative breast cancer. I am not talking only of breast cancer, we do ovarian cancer, we do endometrial cancers, and we do all solid tumors, not the hematological malignancies. So thank you very much.
We will have questions, friends, at the end of the 4 talks. I request Dr. Himanshu and Dr. Pudha here.
So friends, as we have decided, we will have questions and answers in the end. So about the first talk, we will finish the question answer sessions when we begin the session. So we will first finish the first talk, okay? So we will not ask any other questions but related to immunotherapy and chemotherapy, right? So please cooperate because it is otherwise very difficult to edit and put it on YouTube. As I said, this is a wonderful audience, but for all the speakers and the moderators, the world is the audience when you put it on the YouTube. and our channel is already becoming very popular. So many videos there. So kindly note down your questions, and when we begin, you first ask questions regarding the first topic. Now starting the second topic, you showed some wonderful cases, sir. I wanted to ask you regarding one of the malignancies which has shown remarkable improvement with immunotherapy, the lung cancers, even stage 4 lung cancers. So your experience of treating stage 4 cancers with immunotherapy.
Actually, I have a vast experience on treating lung cancers in stage 4 because immunotherapy, we get certain biomarkers done, which is PD-L1, programmed death receptors, PD-L1 and MSI, microsatellite instability. If they are high, if they are more than, PD-L1 is more than 50%, only immunotherapy is the answer. Only immunotherapy is the answer. And if it is less than 50%,
सर दूसरा माइक बंद कर दीजिए, आपका वाला बंद कर दीजिए।
बंद है ये तो ठीक है सर।
so if we have PD-L1 less than 50%, then we can combine chemotherapy with immunotherapy, and we have done that, and we have had excellent results because one of the patients had, and this is done only after molecular profiling. One patient had EGFR mutation, then we gave osimertinib, which worked for 3 years. Then we did another this foundation one for the NGS, we call it next generation sequencing. Then it came to be ROS1, then we gave drug against ROS1, patient lived for another 3 years, and then patient developed resistance, and we gave chemotherapy in that case.
Sir, I wanted to ask you, in stage 4 lung cancers, what is your longest survival on immunotherapy?
On immunotherapy, our longest survival is about 7 years.
Sir, what is the approximate cost of immunotherapy in your center?
Actually, cost, you should not ask about the cost, because I know this is an issue with everybody, that cost depends on the immunotherapy you are giving. There are immunotherapy worth 4 lakhs each injection, but they give patient assistance program. That means with one drug they give 2 free. And there are certain cheaper also alternatives. Cheaper means not very cheap, but about 1.5 to 2 lakhs per injection. So it's very costly affair, and some people who are getting reimbursement either through CGHS, central government and scheme, or through their TPAs, then they are getting immunotherapies.
Sir, Dr. Padar has a question.
In triple negative patient, where you can't give even immunotherapy because the PDL is less than 50%. So what is the next step? Will you use Trodelvy or Enhertu?
Yes. No, Enhertu is not used for triple negative. Enhertu,
Low HER2. It's for low HER2.
it's for low HER2.
Yes.
It's not for triple negative. Because for triple negative means no hormones can be given. Hormone receptor are negative. HER2 is negative. So for triple negative we give chemotherapy. And now we are adding immunotherapy to chemotherapy in triple negative breast cancer. Recent trials have shown that pembrolizumab added to immunotherapy added to chemotherapy gives better results.
But Pembro, if in the PDL1 level is low, then
Irrespective of PD-L1.
Okay.
It has come, Keynote 522 is the trial which has come, and it has shown that immuno has helped chemotherapy. You know, chemo is also immune related.
and when would you like to use Trodelvy in this patient?
Trodelvy we have used in Lajpatnagar. Would you believe it? That first in India we used in Lajpatnagar, Trodelvy. That is sacituzumab govitecan.
We have a very eminent pulmonologist, Dr. P.K. Mangla sir. Sir, he will have a question to ask you, sir.
So one of my patients who I had diagnosed lung cancer in 2008 was still surviving.
Yes.
Still surviving. He took initially chemotherapy, then Jeftinib 10 years,
Yes.
and then finally pembrolizumab.
Yes.
He carried on until, and he was taking care of all his business.
Yes.
So, patients of lung cancer with PD-L1 less than 50% should not receive immunotherapy.
No, they can receive immunotherapy. More than 1% can receive immunotherapy.
Okay.
More than 50% can receive only immunotherapy, no chemotherapy.
Right.
But more than 1% can receive chemoimmuno or immunotherapy.
The only question is that another patient of mine, I diagnosed lung cancer. Once he came to know the cost, he thought 1 or 2 sittings will be enough. When he was told that you have to carry on.
That is the main problem. And one patient, as somebody was asking about LP, that is a sacituzumab govitecan. This is antibody drug conjugate.
Yeah.
And first time in India, I used it in my funeral, and patient got it from US, and I could give it for triple negative breast cancer, and patient responded very well.
The cost is a big factor.
And 20 lakhs each injection.
This treatment is only for
Thank you, Dr.
adenocarcinoma.
Mangla sir, for these wonderful questions. Our very tall academic pillar, Dr. Amal Kalla sir, has some questions to for the first talk.
Sir, I'm attached to Max Panshil for more than 16 years. मुझे एक वो बूस्ट की एडवर्टीजमेंट याद आ गई कि मेरा बेटा आज मुझे हराएगा तो मैं जीत जाऊंगी। तो मुझे बहुत अच्छा लगा कि आज मैं जिनको देख रहा हूँ वो आज से 10-15 साल पहले नहीं थे। So I'm seeing the growth of my Max Panshil, very tremendous, sir. My question, I'm very delighted to see my Max Panshil and the associate like Rajpat flourishing. Dr. Julka has been very, very close to my heart. He treated my wife also. So, sir, knowing from you, is the temperature therapy to avoid alopecia available at your center?
Yes, actually we had scalp cooling, at our center, but we found it not very effective because despite scalp cooling, patients lost hair. And can you believe it that you won't be able to believe that scalp cooling was my idea in 1979. And when I did scalp cooling in a primitive method, I took that hot water bottle and I took that cap and put dry ice on that and did scalp cooling in 1979. And people were surprised, why are you doing? This was an Indonesian ambassador's wife.
Sir, clear my doubt about painless lump. What does it mean?
Painless lump, actually, mostly cancers have painless lumps in the breast. So you should not ignore it.
Because the nerve fibers are destroyed, right?
Yes, because not that all painless lumps are cancers. All painless lumps may not be cancers. They may be ordinary cysts.
I will, since I am on the mother's side, I will give others the questions to ask.
I think the first talk, I would request Dr. Tulsi to ask his questions and wind up the first talk.
Thank you, Dr. Shivan. Those are some excellent questions from the audience. So I forgot to say, not my fault. It's the Max's fault. Which didn't tell me that Dr. Julka is a Padma Shri. Not only that, he's had multiple editorials in NAGM, Lancet Oncology as well.
Sir, I said we have a legend here. I said that.
As Dr. Chauhan says,
Sir, आपने सुना ही है.
But not my fault.
I said one of the greatest luminaries and a legend in the field of oncology.
So to proceed further, Dr. Chauhan, the landscape in oncology for chemo and immunotherapy drugs is rapidly changing. We have a new drug every 6 months now. As Dr. Mangla, where is he?
Dr. Mangla is there.
Okay. As he said, see, pembrolizumab, other MABs also can prolong life in non-small cell lung cancers by 5 years and beyond. The recent trial, the Trident trial on reportretinib, a new generation ROS1 inhibitor, probably 90 times more potent than other MABs. So this is a game changer in non-small cell lung carcinoma, and has revolutionized the treatment for non-small cell lung cancer. So your words on that?
Yes, actually, non-small cell lung cancer is I think, one of the few cancers where the lives have changed, and people are surprised that earlier 1980s we used to give palliative radiotherapy or maybe chemotherapy, but now we are doing molecular profiling of each and every patient. Lung cancer panel we are doing, and then after that we give treatment according to the panels. You know, whatever EGFR mutation, there is ROS1 mutation, there are fusions, there are mutations. So according to each mutation we give the drug, and that drug works for a minimum of 15 to 20 years. And then we have another drug, that those who have no mutations, they get chemotherapy. So chemotherapy has used, now more of targeted therapy has come. So that has revolutionized the treatment of lung cancer.
Right. So my last 3 questions, because of paucity of time, as Dr. Chauhan said, would be Dr. Julka, the Red Devil, the doxorubicin, which was one of the best and the strongest chemo for breast cancer and other cancers as well, but had a lot of cardiotoxicity. Has it been discontinued?
No, it is still continuing. It is still continuing, and we are getting echoes done, 2D echo for every patient every 3 months to assess the cardiotoxicity. And if the ejection fraction, left ventricular ejection fraction is less than 50%, we stop the drug or reduce the dose.
My last question, sir. The Journal of Clinical Oncology, you see, it talked about the ultra-low dose of the immunotherapy drug, nivolumab, for head and neck cancers. Just 6% of the drug used, you see, worldwide, which is, so very effective drug. Just 6% of the drug on head and neck cancer. Your words on that, sir?
Yes. Now, head and neck cancer was, was the last in immunotherapy panels, and that has also come under immunotherapy, where we are giving only very minimal
ultra-low dose
of immunotherapy. That means we give 240 milligram of data, which is this immunotherapy drug. Now we are giving only 20 milligram, sometimes once a month, and that works wonders. And even earlier we used to use Jactolib tablets, and can you believe the tablet cost how much? 2 rupees.
Wonderful, sir. Thank you, sir.
Thank you, Dr. Tulsi, sir, for sticking to the timeline. Dr. Julka, sir, thank you for being here. We consider this to be an absolute privilege, honor to have you on the forum, sir. We move to the second